Hello, my name is Catherine Indiker, VP Business Development at IDDI. I would like to welcome you to our fourth webinar on design and analysis of Phase 2 trials in oncology. We are happy to welcome 160 attendees. Let me give you a quick overview of IDDI. Since 1991, we provide biostatistical and e-clinical services in Phase 1 to 4 clinical trials. These include trial design, biomarkers validation, data management, statistical analysis, medical writing, and support in contacts with FDA and EMA. We have developed our own e-clinical suite, interactive web response for patient randomization and treatment allocation, and also internet coding of medical terms. Over 20 years, IDDI has developed a thorough experience in oncology, cardiology, ophthalmology, and biosimilars. This webinar will present key concepts and current examples regarding the design and analysis of Phase 2 trials in oncology. You will be able to understand the aims, methods, and limitations of Phase 2 trials in oncology, including the important issues of study design, choice of endpoints, the need for randomization, and correct interpretation and decisions in the overall drug development process. The speakers will attempt, to the extent possible, to answer questions after the webinar. If you have a question, please write it in the question panel to the right of your screen and send it to us. Please take the time to give us feedback by filling out the survey form after the end of the webinar. We will address any additional questions you may raise in the survey form and get back to you with answers, as well as recording of the presentation in a follow-up email. Who are our speakers today? Dr. Mark Boyce is Chairman of IDDI, based in Louvain-la-Neuve, and Associate Professor of Biostatistics at Hasselt University in Belgium. Dr. Everardo Saad, founder of Dendrix, a partner of IDDI. So, I'll pass over to the experts now. Enjoy the webinar.
Good afternoon, this is Mark Boyce. Here is the outline of our webinar. Everardo and I will share this webinar, so we will both be covering these issues. The first issue we'll discuss is the goals of Phase 2 trials. The patient selection comes next, and then we will move on to endpoints and designs, which will occupy us for most of this webinar. We will discuss randomized clinical trials. We will also discuss the FDA approval based on Phase 2 trials, and we will discuss the predictivity of Phase 2 trials. I think my voice isn't very good because I hear, it seems that we get a lot of S's. Toi tu n'entends pas. C'est très chantant comme ça. Je le sens, je l'entends, même moi ça me dérange. I can hear S's.
Yeah. That was the problem the other day, but when she listened to the recording this morning, it wasn't bad. I mean,
but I think we should ask someone, let's say, for example, in the Zen room. Because I.
if you share the Zen room, I think it's
Oh, yeah.
Would you perhaps?
You want here. Just open, so you want here. No. But after, yeah.
Can we do a?
But we are using now. It's open, I think. Can you maybe go back now and then check what?
So apparently she can enter downstairs.
No, but I can stop recording and we see what. Yeah. Maybe check now. We're gonna do that.
Good afternoon, Mark Boyce speaking. This is the outline of our webinar. Everardo Saad and I will take turns to tackle the following topics: the goals of Phase 2 trials, patient selection, endpoints and designs appropriate for Phase 2, including randomization, the predictivity of Phase 2 trial results, and whether the FDA approves drugs based on Phase 2 results. Everardo, if you could begin. Ah, tiens, ça ne passe pas. Ah, ça, c'est des problèmes encore pour... Yeah.
Thank you, Mark, and hello to you all. We can think about the goals of phase 2 trials from several different perspectives. There's always a clinical goal, which is to treat patients with a given tumor type with regimens at doses shown to be tolerable in phase 1 trials. Of course, the scientific goal is to determine the activity of a new drug or regimen. And we can also think of a pragmatic goal, which is to decide whether a phase 3 trial is warranted. In other words, a phase 2 trial serves the purpose of selecting active regimens and also rejecting inactive ones. There are also ancillary scientific goals, which are to study the toxicity, pharmacokinetics, pharmacodynamics, and biomarkers. In what I guess was a landmark paper from almost 30 years ago, Witters et al. Have stated that the goal of phase 2 trials is conceptually straightforward, but a number of practical and theoretical problems combine to make it perhaps the most treacherous step in clinical drug testing, and that's what we hope to show you today. Are phase 2 trials common? Yes, if we look at this quick PubMed search for the recent literature in 6 clinically oriented oncology journals, and if we only look at trials, phase 2 trials represent nearly half of all studies, published studies. And likewise, if we look at abstracts presented at ASCO annual meetings, phase 2 trials represent slightly over half of all trials. Patients selected for phase 2 trials should be those most likely to show a favorable effect, of course given ethical and scientific constraints. As a general rule, these patients are those with metastatic disease, good performance status, low tumor burden, and the minimum amount of prior therapy. With regard to prior therapy, the line and extent of prior therapy that is allowed in phase 2 trials depends on the setting, of course, and that will be related to the tumor type and also to the availability of alternatives. Regarding prior therapy, there is this concept of a window of opportunity trial, according to which patients are treated in early lines as long as they can be monitored and treatment can be switched at the first sign of disease progression. This is a very interesting concept, of course, but this example shows a case in which this approach was not necessarily the optimal approach. In this example, Lotinib and bevacizumab in the first line provided very poor results in patients with non-small cell lung cancer. We can perhaps speculate that this may have been done to the lack of molecular selection, which brings us to the next topic, which is the enrichment of the patient population for phase 2 trials. One tries to include patients whose tumors express the molecular targets. And unfortunately, this has been done only in 1 in 5 trials in the recent literature as shown by this review. And this example is a case where a very simple study has been done, immunohistochemistry, which allowed for the selection of patients for a phase 2 trial of Statistical in colorectal cancer. Shall I continue? Are we concerned with timing or just practice, right?
I know. Go ahead.
We won't have the time to do it all, but perhaps we should go to the next transition.
To the transition. So I would be talking about time-dependent endpoints. And now I'm going to give you an example of a phase 2 trial in which a time-dependent endpoint was used. This was a trial of cediranib, a VEGFR tyrosine kinase inhibitor in patients with recurrent glioblastoma. The endpoint here was called by the authors APF6, meaning the proportion of patients alive and progression-free at 6 months. So with using this endpoint, the authors found that the APF6 was 25.8 months.
Percent.
Oh, percent.
and as a statistician, the first question we address is 25.8% good enough? So here I'm going to talk first about the traditional approach to phase 2 trials, where people have compared the outcome in their trial with respect to historical controls. And in this particular trial of cediranib, the authors compared 25.8% of patients alive and progression-free at 6 months with 15% in the historical series of Wong et al. And definitely there was a difference in favor of cediranib. Likewise, when they looked at the median PFS and the median OS in this series, in both cases they found an increased median with respect to the historical series of Wong et al. So in order to test a hypothesis about the proportion of patients who are alive and free at progression at time t, in this case 6 months, in fact we cast the problem in terms of a null hypothesis, in other words a low rate of PFS patients, and an alternative hypothesis which is a high rate of PFS at 6 months. Perhaps we should listen to the recording to see if things have improved.
Hello, my name is Catherine Indike, VP Business Development at IDDI. I would like to welcome you to our 4th webinar on design and analysis of phase 2 trials in oncology. We are happy to welcome 160 attendees. I'll give you a quick overview of IDDI. Since 1991, we provide biostatistical and e-clinical services in phase 1 to 4 clinical trials. These include trial design, biomarkers validation, data management, statistical analysis, medical writing, and support in contacts with FDA and EMA. We have developed our own e-clinical suite, interactive web response for patient randomization and treatment allocation, and also internet coding of medical terms. IDDI's main area of expertise is oncology. This webinar will present key concept and current examples regarding the design and analysis of phase 2 trials in oncology. You'll be able to understand the aims, methods, and limitations of phase 2 trials in oncology, including the important issues of study design, choice of endpoints, the need for randomization, and correct interpretation and decisions in the overall drug development process. The speakers will attempt, to the extent possible, to answer questions after the webinar. If you have a question, please write it in the question panel to the right of your screen and send it to us. Please take the time also to give us feedback by filling out the survey form after the end of the webinar. We will address any additional questions you may raise in the survey form and get back to you with answers as well as recording of the presentation in a follow-up email. Who are our speakers today? Dr. Mark Boyce is Chairman of IDDI, based in Louvain-la-Neuve, and Associate Professor of Biostatistics at Hasselt University in Belgium. Dr. Everardo Saad, founder of Dendrix, a partner of IDDI. So, I'll pass over to the experts now. Enjoy the webinar.
Good afternoon or good morning for those of you who call from the US. Here is the outline of the webinar today. We will take turns. Everardo is a clinician, I'm a statistician, and so we will look at these various topics, both from the statistical point of view and from the clinical point of view. We will review goals of phase 2 trials, patient selection, endpoints and designs. We will discuss the need for randomization, and we will discuss whether phase 2 trials are predictive for the phase 3 results. And finally, we will discuss approvals at FDA that were based on phase 2 trials. Let me begin by introducing Everardo, the other speaker today.
Thank you, Mark, and hello to you all. I guess we can think of the goals of phase 2 trials from many different perspectives. There's always a clinical goal of treating patients with a given tumor type, and such treatment is done with drugs or regimens at doses that have been shown to be tolerable in phase 1 trials. There's, of course, the scientific goal, which is to determine the activity of a new drug or regimen. We can also think of a pragmatic goal, which is to decide whether a phase 3 trial is warranted. In other words, phase 2 trials serve the purpose of selecting active regimens, but also rejecting inactive ones. And there are ancillary scientific goals, which are to study the toxicity, pharmacokinetics, pharmacodynamics, and biomarkers in phase 2. I guess in what may be called a landmark conceptual paper published almost 30 years ago, Withers and colleagues were quite right when they said that although the goal of phase 2 trial is conceptually straightforward, a number of practical and theoretical problems combine to make it perhaps the most treacherous step in clinical drug testing. And we hope to show you that we agree with that statement. Are phase 2 trials common? Yes, if we look at this quick PubMed search for the recent literature, we looked at clinically oriented oncology journals and found that approximately half of clinical trials are phase 2 trials. Of course, the majority of the published studies is not composed of clinical trials, but rather epidemiological or retrospective or other types of studies. But of the clinical trials, nearly 50% are phase 2 trials. Likewise, if we look at abstracts presented at ASCO annual meetings, we conclude that nearly 50% are also phase 2 trials. Patients selected for phase 2 trials should be those most likely to show a favorable effect, of course, given scientific and ethical constraints. These patients, as a general rule, have metastatic disease, good performance status, low tumor burden, and the minimum amount of prior therapy. With regard to line and extent of prior therapy that is allowed in a phase 2 trial, that will depend, of course, on the tumor type and the available alternatives. In other words, the setting in which the trial is done. There is this concept of a window of opportunity trial, according to which patients are treated in early lines, possibly even first line, as long as they are carefully monitored and switched to standard therapy at the first sign of disease progression. Of course, this is a sound concept in general, but as this example shows, it's not always a good way to go. In this case, erlotinib and bevacizumab were used in the first-line treatment of patients with non-small cell lung cancer, and as the authors pointed out, the results were very poor, and this called into question the window of opportunity. But perhaps we may argue that such results may have been due to no selection of patients. In this case, patients were not selected based on molecular enrichment, which brings us to the concept of enrichment. This is very important in phase 2 trials, especially with the targeted agents. While unfortunately, only 1 in 5 of recent trials have used patient enrichment, meaning that most trials have not selected patients based on the presence of molecular targets. This example is from a paper appearing in JCO, in which immunohistochemistry, a relatively easy assessment, was done to select patients for treatment with cetuximab. And in fact, I got this newsletter from JCO today. Some of you may have seen. There is a very interesting paper by Fabrice André and his colleagues, where they discuss various possible ways of enriching for targets in this day and age. let's talk a little bit about endpoints in phase 2 trials. Historically, response rate has been used most frequently, and regardless of the criteria used, of course RECIST is used more frequently today, but regardless of the criteria, patients are typically categorized according to whether they have a complete or partial response and whether they have stable disease or progressive disease as their best response to therapy. Well, with regard to targeted agents, it has been suggested that the proportion of patients with a response or with stable disease, and this proportion is also known as the rate of disease control or clinical benefit, this may be more relevant because many of these drugs are cytostatic and are not expected to produce real responses, and therefore this is another way of trying to assess benefit in phase 2 trials. This is illustrated by sorafenib in hepatocellular carcinoma. If we look at the left-hand panel, we see the results for the phase 2 trial in which the response rate was only 2%. And in fact, if we look to the right of the slide, for the phase 3 study, the response rate was exactly the same, only 2%. But there was a clear survival improvement, which certainly shows that for these agents, a response is not necessarily a good indicator of treatment benefit. It's important to bear in mind, however, that responses may be analyzed as a continuous variable. In fact, we can look at this variable as a continuous variable that has been categorized historically. But and we'll come back to that later. Mark will briefly cover some of the statistical aspects of this. But you know, in order to account for the fact that responses are continuous variables, people have used waterfall plots, such as the one we see on this slide. In these plots, each individual patient have their change from baseline indicated by the sizes of the bars, and sometimes color coding is used to indicate the category of disease response. More recently, time-dependent endpoints such as TTP, or time to tumor progression, PFS, or progression-free survival, or even overall survival have been used. And sometimes an emphasis has been given to certain time points, for example, 6 months. This is an example of what I just said in the previous slide. These authors assessed cediranib for recurrent glioblastoma, and they used what they call APF6, which was defined as the proportion of patients alive and progression-free at 6 months. And their results indicated that the APF6 was 25.8%.
Now, obviously, as a statistician, the first question I would raise about this result is, was 25.8% a good enough PFS at 6 months? And the way that authors of the cediranib trial went about this was to compare 25.8% with a historical series of patients where the progression-free survival rate at 6 months was in fact 15%, about half of it. And so they claimed that 25.8% was better than 15%, which was the historical figure. If you look at the other endpoints they looked at in this trial, progression-free survival and overall survival, there as well, the median that they observed in the cediranib trial was in excess and far in excess of what the historical figures suggested. So this trial was called a positive trial. The results were exciting, and exciting enough to go further with the development of this drug. So how was this trial designed? In fact, this trial was designed as a non-comparative, non-randomized, single-arm phase 2 trial, where in fact the outcome of interest, in this case the proportion of patients alive and without progression at 6 months, could be denoted R, and this rate is actually, or this proportion is actually compared with historical figures. So the historical figures are in fact two types of historical figures. A low rate of progression-free survival at 6 months, R0, which is the null hypothesis, and a high rate of progression-free survival at 6 months, which is the alternative hypothesis. And the hypotheses we test are casted as a null hypothesis. The progression-free survival rate in this trial is less than the low rate historically, versus the alternative that the rate of progression-free survival at 6 months is larger than the historical figures suggest. And so if we compare the truth, which we don't know, which is that the null hypothesis is true or that the alternative hypothesis is true, we can actually cross-tabulate the true state of affairs with the decision we make at the end of the phase 2 trial. And the decision we make at the end of the trial is either to reject the null or to reject the alternative. If we reject the null, we accept the treatment. That means we believe, rightly or wrongly, that the PFS rate at 6 months is in excess of historical figures. If that is true, then we have a true positive outcome. If that is not true, we have a false positive outcome. Likewise, if we reject the alternative at the end of the trial, we may have a true negative result if indeed the truth is that the progression-free survival rate is low, or a false negative outcome if in fact it is true that the progression-free survival at 6 months is high, but we fail to see it. And so the outcome of this trial can be either right or wrong. The right outcomes are shown here in green, and the wrong outcomes are shown here in red. And the way we designed the trial is to try and keep the probability of wrong outcomes, the false positive or the false negative, within limits that we pre-specify. So we're going to fix the probability alpha, the probability beta, the low response rate, and the high response rate of interest. And here by response rate, in this particular trial, I mean the progression-free survival at 6 months. So for the phase 2 trial of cediranib that we've seen the results of, this is probably how the trial was designed. The low rate of progression-free survival at 6 months was chosen to be 5%, and the high rate of progression-free survival at 6 months was chosen to be 15%. And this was suggested, as we saw before, based on historical series of patients. In terms of the probabilities of a false positive and a false negative, these authors chose rates of 20%. So both of these probabilities were set at 20%. And with these parameters, the design consisted of treating 28 patients. As you may recall, in fact, they treated 31 patients. But the design calls for 28 patients, and in fact, if at the end of treating these 28 patients, we observe that 2 patients or less, in other words, 0, 1, or 2 patients, are still alive and progression-free at 6 months, we will declare that the therapy is not good enough. If, in contrast, we have 3 or more patients progression-free and alive at 6 months, we will claim that the therapy is good enough to undergo further testing. So this was a one-stage design where we treat all the patients at once and then we look at the results. This has been generalized by Richard Simon to a two-stage design where in fact we allow ourselves to look at the data earlier than before we've accrued all the patients in the trial, and we test the same hypotheses as before on the smaller sample size that we have already. There are in fact 2 versions of this two-stage design, one called the minimax design and one called the optimum design. So in the case of the cediranib trial, the optimum design would look like this. The first stage, which is shown here, would consist of treating 12 patients. If among these 12 patients, the number of patients alive and free of progression at 6 months was 0, in other words, none of them are still alive and progression-free at 6 months, then we can already stop the trial there, and with 12 patients, we are in reasonably good conditions to reject this treatment as being of no interest. If 3 or more patients are progression-free and alive at 6 months, we actually could already stop the trial and declare that the therapy is very promising and go further to other trials with it. If, however, we had 1 or 2 progression-free and alive patients at 6 months, we would then proceed to the second stage. And the second stage would look very much like the one-stage design. We would add 21 patients to the 12 that we already treated in first stage for a total of 33 patients. And again, we would look at how many patients we have who are alive and free of progression at 6 months among these 33 patients. If the number of patients was only 1 or 2, again, we would reject the therapy. And if it was 3 or more, again, we would accept the therapy. So the two-stage design is in fact a generalization with an interim analysis of the one-stage design. There have been countless numbers of extensions of these designs, and we won't go into all of them. Let me just mention a few important ones here. Ensign and colleagues have proposed a three-stage design with a very early stopping for inactivity. Dent and colleagues in Canada have proposed to use a multinomial endpoint. So instead of looking at response versus non-response, or patients being alive and free of progression at 6 months versus those who are not, these authors use the categories of response and look at CR plus PR, complete and partial responses, versus stable disease versus progressive disease. So that is 3 outcomes that are possible for each patient, and it's called the multinomial endpoint. In fact, a 3-category endpoint. And they've designed and they've proposed a design that uses such an endpoint. Another situation can occur whereby you are interested in efficacy as well as toxicity of a new drug, and in that case you have 2 endpoints of interest. One could be the tumor response or the PFS rate at some point in time, and also the toxicity of that drug. For example, a specific toxicity that you want to control for, let's say for example cardiotoxicity. And finally, Dan Sargent and his colleagues at the Mayo Clinic have proposed a 3-outcome design, which again generalizes the design that we've seen so far in terms of having 3 possible outcomes at the end of the trial. The trial, as before, could reject or accept the null hypothesis and the alternative hypothesis, but the trial could also end up being inconclusive, in which case essentially the trial would not be able to answer conclusively if the drug was worthwhile or not, and other trials would therefore be required. So we won't go into the details of these trials because we would prefer now to move to another topic, which is why we need to control for the response rate or the progression-free survival rate. Everardo?
Well, following Mark's comments, it should be evident at this point that the question, is this good enough, is a hard one to answer because we need to have a control group. There are basically 2 ways of controlling responses in phase 2 trials. Let's see the first way now, and then I'll come back to the second way. The first way is to use patients as their own control, and this is done if one divides the TTP on the last therapy, this therapy being the one of interest, by the TTP of the therapy immediately preceding that, thereby obtaining a TTP ratio. This ratio, the rationale for using this ratio is the fact that if only natural history of a tumor is at play, the TTP ratio should not exceed 1. In other words, always the TTP for a given line of therapy should be shorter than the TTP of the previous line of therapy. That's the rationale behind it. So von Hoff et al. And other authors have suggested that a TTP ratio that is significantly different from 1 could reflect drug activity. And they chose the 1.33 or 1.3 cutoff as indicative of activity in order to account for random variability. This is an example where this has been used. This is actually a retrospective analysis of a study in GIST, gastrointestinal stromal tumors. In this study, patients were initially randomized to receive 400 or 800 milligrams of imatinib. And patients who did not have a response or whose disease progressed on the 400 milligram arm could switch to the 800 milligram. And on this table, we can see the proportion of patients with a TTP ratio greater than 1.33 across the spectrum of disease of tumor responses. We can see that as we move from progressive disease in the previous line to stable disease and then to partial response, the proportion of patients with a TTP ratio greater than 1.33 increases. And this nicely illustrates that TTP ratio may be indicative of drug activity. More recently, von Hoff and colleagues have done a phase 2 trial in which they selected treatment according to a molecular panel of tumors, trying to find which agent could be used to target the alterations that were found to be present. The null hypothesis of this trial was that the response rate using this approach would not be lower than 15%. And actually that's what this p-value is about. This is a comparison of the response rate that the authors found, 27%, versus the null hypothesis of 15%. In other words, 18 of 66 patients responded, and the authors noted that none of these patients would have received the same drug through physician's choice if the molecular panel had not been used. And in fact, this is, of course, their conclusion, but we can argue that only a randomized trial might prove that a similarly high, a TTP ratio greater than 1.3 rate could not be found if physicians had the chance to choose the treatment, and therefore the choice had not been made based on molecular profiling. There's also an argument that has been made recently by Mark and his colleagues in a letter to JCO. There is a statistical caveat when using TTP ratio. In fact, in order for TTP ratio to be a useful endpoint, there needs to be a correlation between a certain TTP in a certain line and TTP, for example, in first line and TTP in the second line. What this plot shows is that for each patient, there is really no correlation between TTP in first line and TTP in second line. And this questions whether TTP ratio is really a good endpoint for phase 2 trials. And this brings me to the second way of controlling for responses in phase 2 trials, which is, of course, through randomization. We know that historical data can be very misleading, and of course, the results of a phase 2 trial may heavily depend on patient selection. I want to show you an example of a situation in which a phase 2 trial led to many other follow-up studies because it was initially considered positive or very promising. At some point, interferon alpha was considered to be active in colorectal cancer. This was due to the fact that an initial small phase 2 trial found a response rate of 81% when only 16 patients were treated. This led to many phase 2 trials which aimed at confirming those findings, and for those 15 trials, the pooled response rate was only 30%. This led to small phase 3 trials, 5 trials actually, and the pooled response rate for those trials was only 22%. And one additional trial was run by the sponsor with 245 patients, only 50 of which responded, for a final response rate of only 20%. So this is an example in the literature where an initially promising result in phase 2 trials was not confirmed by extensive research, and this may have been done to the lack of randomization in the initial trials. So in another landmark paper of almost 30 years ago, Simon and colleagues described the mechanics of randomized phase 2 trials, and they pointed out that this design is of value when several drugs or schedules are available. And I think this is very relevant to targeted agents, many of which may have their activity conditioned upon regimens and schedules. of course, randomization controls for selection bias, which is the most relevant bias when we interpret the results of phase 2 trials. This is a graph from a paper from JCO in 2005 that clearly shows an increase in the number of randomized phase 2 trials being published, and this is just a witness to the increasing interest in this type of study. We can look at phase 2 trials at various, according to various different features, and one of the ways of looking at them is to try and divide them according to at least 3 types. The first type of a randomized phase 2 trial is the so-called pick the winner approach, in which 2 or more experimental arms are included. Then there is, let's say, an experimental versus control approach, which can be a non-comparative trial, or it can compare the groups with or without adequate power. And Mark will cover that in his follow-up slides. And then we'll come back to the third type of phase 2 trial, which is the randomized discontinuation design.
So let's look at these different designs in turn. The first design Eduardo spoke about is the pick the winner. And here is an example of a pick the winner design which tested 2 different doses of a new drug, gefitinib, in patients with non-small cell lung cancer. And here is one of the results of this trial. It actually shows the proportion of patients who had symptom improvements in the 2 doses, the 250 milligram dose and the 500 milligram dose. And what we see from this graph is that clearly the 250 milligram dose was about the same, if not slightly better, than the 500 milligram dose. And so based on this and toxicity considerations, the 250 milligram dose, for better or worse, was chosen as the dose to be used in future trials. Now the question statistically again is, can we claim that these 2 results are identical, or is one better than the other? And the way we design a pick the winner trial is to compare 2 experimental groups, could be 2 doses of the drug as we've just seen, could be 2 schedules, or it could even be 2 different drugs, X and Y, and we're going to compare the response rates of these 2 drugs, which we here call delta. Delta is just the difference between the response rates, or it could be the difference between the proportion of patients, again, progression-free and alive at 6 months, or any other proportion that we find of interest. So the way the trial is designed is in fact to look at this difference between the response rates, delta, and to assume that the true delta is larger than a certain difference. So here, for example, if we expected a low response rate of 10%, we might wish to select of these 2 regimens the one that has a 15% better response rate than the 10% which we assume to be the low rate of interest. And we want to have a very high probability of making the right choice. In other words, we want to have a very low probability, in this case 5%, of choosing the wrong treatment, the regimen or the dose or the drug that in fact has the lowest response rate, when in fact we want to choose the one that has the higher response rate. And so here is, for example, a design where the low response rate is 10%. The difference we're interested in is 15%, which is of course a big difference. We want to have 5% probability of making the wrong choice. And the design is in fact to consist of treating 68 patients, 34 in each arm, and to simply choose whichever arm gives us the highest response rate, the highest observed response rate. And we can be pretty sure that if one drug or one dose or one regimen is truly better than the other, we're going to make the right choice. So, of course, we need to look at the probability of choosing the better drug, not just for the differences that we are interested in, which is 15% or more, but also for smaller difference. And what this slide shows, assuming a low response rate of 10%, is the probability that the trial will choose the right treatment under different hypotheses about the high response rate. So, if in truth the low response rate is 10% and the high response rate is 25%, we have designed the trial in such a way that we have 95% power or 95% probability of making the right choice for that difference. However, if the difference between the two regimens was less than 15%, perhaps even 0, in which case the high response rate would be the same as the low response rate, 10%, in that case we would have less than 95% probability of making the right choice. And in fact, if the two doses or drugs or regimens didn't differ at all, we would be under the null, as we say in statistics, and we would, for that case, have exactly 50% of making the right choice, because the two drugs would be equivalent, would have the exact same response rate, and in fact doing the trial would be equivalent to flipping a coin, because we would choose one of these two drugs at random. One of them might appear to be better than the other just by the play of chance. And so the pick the winner design can be of interest in some very peculiar circumstances where for some reason we expect one of the drugs to be much better than the control or the other drug. And in that case, this pick the winner or selection design can be of interest. Another case where it can be interesting is if we have no preference for either dose in terms of toxicity, for example, and we just want to choose out of two possible doses the one that we believe might be the better. In that case, the pick the winner design may be an option. Obviously, in most cases, pick the winner would not be the way to go, and we would design phase 2 trials in a manner that is very similar to the manner I described before. In fact, where we have an experimental treatment, a new drug that we want to assess, versus some control treatment that we know very well. So the control treatment here could be the standard drug or regimen that is appropriate for the patients with this condition, and the experimental drug would be randomized vis-a-vis the control drug. Here we have a question about the response rate, and again response rate is taken here in its general meaning. It can be the proportion of patients who are progression-free and alive at 6 months, but we have a question about this response rate compared with a response rate that we believe, rightly or wrongly, we know fairly well. So in fact, because we have more information, we have more need for information with the new drug than with the controlled standard drug, we might wish to randomize twice as many patients in the experimental group than in the control. And in fact, it doesn't really matter to do that, because the design consists of sizing the trial only for the experimental arm. So we're going to use, in fact, a single-arm phase 2 design for the experimental drug, and we're just going to randomize patients vis-a-vis a control group. But we will not size the control group to test any peculiar hypotheses. So the hypotheses we test are the same as in a single-arm design, whereby we test the response rate Rx vis-a-vis some historical response rates that we believe to apply. And the response rate in the control group will just serve as an informal comparative group, but we will not formally compare the two groups at the end of the design. Now, of course, this opens a lot of it raises a lot of questions, and very often when we design trials like this, people ask, but what is the point of randomizing if we don't compare? So the other way we could design a randomized phase 2 trial would be to indeed intend to compare the two response rates, and again look at the difference in these response rates, Rx minus Ry, the difference between the response rate in the experimental group minus the response rate in the control group. Now here the null hypothesis is that in fact the experimental arm is worse than the control. This is the situation we definitely do not want. If the new drug has a lower response rate than the standard drug, definitely the new drug should not be used. And so we're going to test this one-sided hypothesis, the null that the response rate difference is against treatment versus the alternative that the response rate difference is in favor of the new treatment. And the sample size will be calculated for a specified alternative. For example, using the same numbers as before, we could think that the response rate with the standard drug is 10%. The response rate with the new drug is 15% higher, 25%, and we're going to use a one-sided alpha greater than 5%. If we used an alpha of 5%, we would essentially be designing a phase 3 trial. Remember, now we talk about phase 2 trials, and so we can relax, according to some people at least, I'm not among them, but some people claim that we can relax the alpha level or the significance level and use, for example, a 10% or a 20% significance level instead of the usual 5% level that would be appropriate for a phase 3 trial. The power, similarly, which we want to be fairly high in a phase 3 trial, for example 90%, we would relax that and perhaps agree with a lower power in the range of 60 to 80%. So if we were to use this approach, which is what we call a comparative underpowered approach to make a distinction between phase 2 and phase 3, here is the kind of numbers that we would end up with. If we were to randomize an underpowered phase 2 trial, we would use a one-sided test, as I indicated before, whereas if we were to do a proper phase 3 trial to compare the response rates, we would use a two-sided test. The significance level in a phase 3 trial would have to be 5% or even less than 5% in some cases. In a phase 2 trial, we might be content with a 20% one-sided alpha level or significance level. The power, which we would want to be perhaps 90% in phase 3, we might settle for an 80% power in phase 2. And look at the numbers of patients we would need in these two scenarios. For the randomized phase 2 study, 70 patients, 35 per group would be sufficient. Whereas for the same difference of interest, a 15% difference in response rate, we would need about 4 times more patients for a properly powered phase 3 trial, roughly 260 patients, 130 in each group. So here you see the difference between relaxing the parameters of interest, the alpha and the beta levels, compared with what we do in phase 3. And so sometimes randomized phase 2 trials have been called the poor man's phase 3 trial, simply because they require less patients to reach a conclusion. Obviously, the error rates won't be the same. They will be much less reliable. The last line in this table shows the difference, delta, that would be required to be observed to reach statistical significance. So delta, again, is the difference between the response rate, Rx and Ry, and you would have to observe a 7.5% difference in response rate to reach significance in a randomized phase 2 trial, whereas you would need to reach a 9% difference in response rate to reach significance in a phase 3 trial. Note that in both cases, 7.5% and 9%, in both cases are less than the difference that we claim to be of interest. And that, of course, is a design feature of all trials. You reach significance for a difference that is lower than the parameter or the difference of interest. So what this slide showed was that if we want to compare response rates or progression-free survival rates at 6 months, these are so-called binary endpoints. And no matter how we look at these endpoints, they require a lot of patients to reach significance for any kind of realistic differences between the groups. So can we do better than that? And the answer is definitely we can. But if we want to do better than that, we need to look at other endpoints. And what I'm going to show in the following slides is that if we have a biomarker that we can use in our phase 2 design, we can then do much better than using this underpowered approach that I've just described. And here I'm going to use an example. There is a paper that was published on this example, but not with the biomarker that I'm going to talk about. The paper just describes the design of this phase 2 trial. It was a trial of a vaccine in patients with prostatic cancer, and this vaccine was targeting the MUC1 antigen. So patients who had prostatic cancer and had elevated PSA after prostatectomy and documentation of MUC1 antigen expression were in fact randomized between 2 schedules of this vaccine. And 20 patients were randomized to receive the vaccine once a week. 20 patients were randomized to receive the vaccine every 3 weeks. So this was a randomized comparison of 2 different schedules of the same vaccine. Here is how the trial was designed. These authors used PSA response rate as the outcome of interest. The low response rate of interest was 5%, and the high response rate of interest was 25%. Here is the definition of a PSA response. The PSA has to decrease to less than this value or to less than 50% of baseline level for at least 4 weeks before you can claim a response. And so this design was actually very classical. You compared 2 different response rates, and you had a relatively sizable difference between the response rates in the 2 schedules of this vaccine. There were secondary endpoints, but as in actual fact, after they did the trial, they had no PSA response in any patient. And so the trial, you could say, was a total failure. Now, was it really a failure? In this trial, they also measured PSA in these patients, and we know from meta-analyses and randomized trials that PSA is not a good surrogate for clinical endpoints in prostatic cancer, but it's a very useful biomarker that in fact reflects the tumor in these patients, the tumor behavior in these patients. So because there were tumor measurements over time, we decided to reanalyze this phase 2 trial using PSA measurements. And here is what we observed. We had tumor PSA measurements on about half of the patients. And here is the pattern of PSA for the weekly schedule and for the every 3-week schedule. So each line on this so-called spaghetti plot is a patient. So you see that in most patients the PSA is going up with time. In fact, this is not PSA but log PSA, so we took the logarithm of the biomarker. And what you see here in red is the mean PSA for the whole group of patients before treatment and after treatment with the vaccine. And it's kind of hard to see on this slide, but you see that the slope of this curve, or this straight line, is actually changed more by the weekly schedule than by the 3-weekly schedule. Now, perhaps this is not clinically relevant, but it is statistically very interesting. And so we can model these data using this model, which looks complex, but in fact isn't so complicated. If I tell you what is in the model, we model the log PSA, so these are the PSA levels over time, and the model contains the following terms: an indicator variable for the 3-weekly regimen, called T, an indicator variable for the weekly regimen, called W, an indicator here for period, -1 prior to baseline, +1 after baseline under treatment, an indicator here for the measurement times, Tij, so there are J measurement times for each I patients, and then all of these at the end here are interaction terms, interactions between these various effects in the model. So it's a fairly complicated model, but one that is surprisingly easy to fit using standard software. And when we fit the model using standard software, even though we only have 21 patients in the analysis, we can see extremely significant p-values. What we see here is that the treatment had an effect on PSA. If we compare the pre-baseline versus the post-baseline PSA measurements, we see that both schedules tended to increase, or to decrease the slope of the PSA increase. So both treatments had an effect, and very highly significant effect. If we compare pre-baseline versus post-baseline separately for the 3-weekly schedule and for the weekly schedule, we see that the weekly schedule has a much more pronounced effect on the slope of the PSA measurements, or the logarithm of the PSA measurements, than the 3-weekly schedule. And indeed, if we compare directly the weekly versus the 3-weekly schedule, we in fact have no difference pre-baseline, which is normal, because prior to randomization the patients didn't receive any vaccine, so there shouldn't be any difference here. And in contrast, post-baseline, when the patients were treated, there was indeed a statistically significant difference, and highly statistically significant difference, in favor of the weekly regimen compared with the 3-weekly regimen. So again, this example shows that with very few patients, if you have the luxury of a repeatedly measured biomarker, you can have much more statistical power than if you compare response rates or progression-free survival response rates. And in fact, if we go back to the sodironib trial that we already showed at the beginning of this webinar, indeed these authors used a number of different biomarkers. They used MRI, and they used plasma and urinary biomarkers at multiple time points. And indeed the paper goes into analyses of these biomarkers. The only problem with this paper from a statistical point of view is that it wasn't a randomized trial, and therefore all they can do with the biomarkers is compare the value of the biomarker after treatment or under treatment vis-a-vis the baseline value, instead of being able to compare 2 regimens or 2 treatment groups. So this is a very nice example of using biomarkers. It would have been better even if they had randomized the patients. Now, of course, sometimes we don't have biological biomarkers. We don't have imaging. We don't have anything that is repeatedly measured except tumor size. And if we think of it, tumor size is a biomarker. It does reflect how the tumor reacts to treatment, and also it reflects the natural history of the disease. So these authors, Carrison and colleagues, have proposed that we can use tumor size as a biomarker in just the way I showed with PSA, and use repeated measures of tumor size as in fact an indicator of treatment effect in randomized phase 2 trials. And I believe personally that this is something we haven't really been doing enough of. So perhaps now we can begin to design phase 2 trials in a manner that makes sense from a statistical point of view. Eduardo?
Okay, now talking about the randomized discontinuation design. This study design has been devised as a way to distinguish drug activity from the natural history of a given tumor, especially if it's an indolent tumor. According to this design, patients are first treated for a certain period of time with the agent of interest, and then patients with stable disease are randomized to either continue the same therapy or to switch to placebo. Patients who have a response are not randomized. They continue to receive active therapy, and patients who do not have either a stable disease or a response, in other words, patients whose disease progress, are taken out of the study. This design has been used recently in a trial of sorafenib in renal cell carcinoma. In this trial, it was a randomized phase 2 trial. Patients were first treated with 12 weeks of sorafenib, and those who were with stable disease were then randomized between continuing sorafenib or switching to placebo. And what the Kaplan-Meier plot clearly shows is that the progression-free survival was better with sorafenib. This is interesting, but we need to point out some caveats. Although this design has potential advantages, especially in the case of targeted agents with expectedly low response rates, it has been argued that it has some problems. One of them is that the randomized component of the trial only allows for assessment of treatment duration, because patients who have a response are taken out of the study, and so we only randomize patients who have stable disease. Also, this design tends to be inefficient in comparison with a simple randomized design, just because you have to include a sizable number of patients initially, and many of whom will not be randomized. And finally, since there is comparison, the sample size must be calculated as for a phase 3 trial, which also is a potential disadvantage of this design. Well, are phase 2 trials predictive? In this sense, we're talking about how phase 2 trials are able to predict the subsequent efficacy of an agent when it goes to phase 3. Sometimes they are predictive, sometimes not. In this review of the literature, response rates were used and compared between phase 2 studies and phase 3 studies for the same agents. And what this graph shows is that there is a mean difference in response rates between phase 3 and the preceding phase 2 studies of 13%. Of course, the response being higher in phase 2 than in phase 3, which probably reflects the selection of patients for phase 2. The predictive factors for a successful phase 3 after phase 2 have been investigated recently, and some of the factors are shown here. Larger sample sizes tend to predict for higher successful outcomes in phase 3. Phase 2 trials with multiple rather than single institutions are also predictive, and also sponsorship by the pharmaceutical companies have also been found to predict for a higher successful phase 3 following phase 2 trials. Finally, what is the view of the FDA regarding phase 2 trials for drug approval? Not too bad, actually. They often publish reviews of their experience over the past few years. Many accelerated approvals, which later require confirmatory evidence from follow-up studies, are granted, in fact, on the basis of results from phase 2 trials, or at least single-arm studies, most of which are phase 2 trials. For example, 15 of 22 approvals granted between 1992 and 2004 were based on single-arm studies, and 6 of these were later converted to a regular approval. Between 2005 and 2007, 16 of 53 approvals were based on single-arm studies, noting that 39 of 53 were regular approvals and not accelerated approvals. So these are our tentative conclusions for this webinar. We hope to have shown you that although many designs are available for phase 2 trials in oncology, many phase 2 trials have failed to really inform the scientific community regarding drug activity and of course the chances of success in phase 3. So when designing a phase 2 trial, one should consider patient stratification, for example, through population enrichment, as we have seen. One should also choose a sensitive endpoint, and we believe molecular markers that may be measured repeatedly is really the way to go. And finally, randomization is an essential feature of a trial that aims to be informative. So now let me hand it back to Mark, who will conclude this webinar.
Thank you, Eduardo. We've used up most of the time that we had. We were hoping to be able to take questions at the end of this, but unfortunately there will not be enough time to do so. When you leave the webinar, you will be asked to fill in a survey. If you have questions, if you don't mind writing your questions in the final survey, we will make sure to answer you personally and by email. So you will receive an answer to your questions if you send them to us with the final survey. I should also tell you that we will also send you a PDF version of this webinar if you're interested in looking at the slides and have the references, and also a recording of the whole webinar in case you want to play it again and hear our sweet voices a second time. So let me finish by introducing the next IDDI webinar, which will be on a very different topic on independent data monitoring committees. That next webinar will take place in May 26, 2011, and it will be given by our friend and colleague Jay Herson, who's a professor at the Johns Hopkins Bloomberg School of Public Health in Baltimore, and Jay is a worldwide expert on independent data monitoring committees. He will cover a lot of issues related to trials in pharmaceutical companies and also trials of cooperative groups. So we hope that you will attend that seminar, that webinar, and with that I will close this webinar and wish you a very good day or evening. Bye-bye.